Welcome to this presentation on trauma, a developmental model of health. I'm Dr. Brazier. In the psychopathology course, we often use the medical model to understand mental illness. We look at symptoms that cluster into syndromes, and in order to assess and diagnose, we ask the question, what's wrong with you? But a trauma-informed model asks a different question. The trauma-informed counselor asks, what happened to you? And a trauma-responsive model takes it one step further and asks, how did you adapt in order to survive? From this perspective, symptoms are seen as strategies that survivors of trauma used to cope, and many of the disorders in the DSM are conceptualized as the aftermath of having survived experiences of overwhelm in which their sense of safety in the world was profoundly shaken. So in those early years of life, our personalities are formed. Researchers studying the field of epigenetics are increasingly recognizing that the trauma that one generation survives and does not heal from negatively impacts the next generation. Additionally, prenatal factors such as maternal stress, traumatic birth experiences, and abuse and neglect in infancy, the toddler years, and childhood all shape how a person develops. We've known for a while about the role that attachment plays in healthy development. This is largely due to two pioneers, John Bowlby and Mary Ainsworth. Bowlby looked at the primary caregiver and how they provided a safe base from which the child learns to emotionally regulate and courageously explore. Bowlby also helped us to understand the ways in which attachment ruptures can be repaired and healthy growth can continue to occur. And then Mary Ainsworth gave us the strange situation experiments, in which a child was confronted with an experience of being left with a stranger and then reunited with their primary caregiver. Ainsworth studied patterns or styles of attachment in these children, and she realized that these styles tended to generalize to adulthood and to predict the way in which those adults relate. So a person is either securely attached or insecurely attached. A child can securely attach with a primary caregiver who is quick and sensitive and consistent. The caregiver doesn't have to be perfect, only fairly consistent. And when the caregiver is consistently caring, then the child feels secure and is therefore able to explore their world and feel happy. The child believes and trusts that their needs are going to be met. But when a caregiver is distant and disengaged, such as when they have not yet healed from their own trauma or they're depressed or addicted to a substance, then the child becomes emotionally distant and not very explorative. The child subconsciously believes that their needs probably won't be met. Or when a caregiver is inconsistent, sometimes sensitive, but sometimes neglectful, the child becomes anxious, insecure, and angry. The child can't rely on their needs being met, and they become preoccupied with worry. Worst of all, when a caregiver is frightening, or passive, or vacillates between these extremes, the child becomes disorganized. They are at times depressed, passive, and non-responsive, and then at other times they're angry and they lash out. They're severely confused, with no set strategy to get their needs met. Attachment styles highly related to many disorders found in the DSM, including anxiety-related disorders and personality disorders. So here's an example of attunement in action. This video shows the Tronic still face experiment.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions. They turn away. They feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
So this idea that it's not about perfection, but it's about consistency and it's about repair. And when there is no repair, when there is no coming back together, then the child concludes that I can't trust that my needs are going to get met. And the way in which the strategy that they then use to go about getting their good needs met in the world can end up being pathologized as symptoms and looked upon negatively, even though that was never the child's fault. The child didn't choose to be born into a family with caregivers that were incapable of taking care of them well. Okay, so the Adverse Childhood Experiences, or ACE study, is one of the largest investigations of childhood abuse and neglect and later life health and well-being. It was conducted at Kaiser Permanente from 1995 to 1997 with 2 waves of data collection. Overall, they collected 17,337 physical exams with confidential surveys. The ACE survey is only 10 questions long with answers of yes or no. You simply count the number of yes answers and they add up to your ACE score. Researchers found 10 factors that predicted the development of a slew of physical and mental illnesses: emotional, physical, and sexual abuse, domestic violence, substance abuse, mental illness, separation or divorce, criminal behavior, and emotional and physical neglect. So the ACE study found that this is the mechanism by which adverse childhood experiences influence health and well-being throughout the whole lifespan, from conception to death. The more ACEs a person has, the more likely they become to develop a whole range of difficulties in later life. Adverse childhood experiences lead to disrupted neurodevelopment, which leads to social, emotional, and cognitive impairment, which leads to the adoption of high-risk behaviors such as sexual promiscuity, smoking, abusing substances, and disordered eating. In turn, the person develops disease, disability, and social problems, which can result in isolation. And then all of this culminates in early death statistically. Researchers also found that adverse childhood experiences are common. Almost 2 out of 3 of study participants reported at least 1 ACE, and more than 1 in 5 reported 3 or more ACEs. As the number of ACEs increases, so does the risk of developing psychological and physical illnesses. People with higher ACE scores are more likely to succumb to alcoholism and alcohol abuse, early initiation of smoking and smoking addiction, and illicit drug use. They're at higher risk for chronic obstructive pulmonary disease, depression and suicide attempts, health-related quality of life problems, ischemic heart disease, and liver disease. They're also at increased risk for poor academic achievement, poor work performance, financial stress, intimate partner violence, risk for sexual violence, early initiation of sexual activity, adolescent pregnancy, unintended pregnancies and fetal death, multiple sexual partners, and sexually transmitted diseases. So ultimately, the higher the ACE score, the younger the person tends to die, and the more suffering their life tends to be characterized with. Now, this doesn't mean that every person with a high ACE score is doomed to a terrible life, but it does mean that statistically they are more vulnerable. So the purpose of the ACE study with over 17,000 participants was to create a quick and simple questionnaire screening tool that primary care doctors could use to help them recognize vulnerability and test and treat accordingly. But unfortunately, it hasn't had the impact that researchers had hoped. Although a person's ACE score is highly predictive of all these medical problems, and although the ACE questionnaire takes only a few minutes to complete, most doctors still don't use the ACE questionnaire. So as you know, the current DSM requirements for PTSD begin with an event. The person has to have experienced, witnessed, or learned of a traumatic event or events involving actual or threatened death or serious injury of family member or friend that was violent or accidental. Or they must have experienced extreme or repeated exposure to aversive details of the traumatic event, like in the case of first responders and police officers. So this doesn't apply to media, movies, or pictures. And then they must have one or more intrusion symptoms, including distressing memories, dreams, flashbacks, distress and or physiological reaction to triggers. They have to have one or more avoidance symptoms, including avoiding memories, thoughts, feelings, external reminders, and they have to have two or more negative alterations in cognition and mood, including inability to remember, negative beliefs, distorted cognitions, negative emotional state, diminished interest, detachment, and anhedonia, or the inability to experience positive emotions. And finally, they have to have two or more symptoms of marked alteration in arousal and reactivity, including irritable behavior or angry outbursts, reckless or self-destructive behavior, hypervigilance, exaggerated startle response, concentration problems, sleep disturbance. I want to focus on that first requirement, which must be present in order to meet specific criteria for PTSD, exposure to a specific type of event. I want to share with you one mother's story from the website Steam Powered Family. This is Shelley. My son has PTSD, post-traumatic stress disorder. Except he can't have PTSD because the medical definition of PTSD requires that the cause be a remembered event. So although he suffered complex and prolonged trauma from before he was even born and through his first year of life, traumas that still affect his every moment and every breath, he can't be diagnosed with PTSD. There's a movement to get a new diagnosis recognized, developmental trauma disorder, since in reality the issue is that PTSD or trauma experienced later in life is very different from trauma experienced while the brain is still forming. It needs its own definition, but as a parent trying to get help for my son, it's incredibly frustrating that so little is known about the effect of trauma on children. Over the past years, since our adoption was completed and we experienced our son's struggles firsthand, I've returned to school in my studies of the brain, trying to help my son heal and grow into the amazing adult I know he's meant to be. And there's at least one issue that I want to bring up and that needs to change in society. One of the most maddening things I hear is that my son was too young to remember the traumas that he experienced as an infant and toddler. Therefore, he'll be fine. This is completely and utterly wrong. In fact, it's the complete opposite. Childhood trauma is often complex and can be catastrophic, leaving a lifetime of struggles in almost all facets of life. This is significantly true of trauma exposure during the prenatal and infancy stages, the roots in the trunk that I showed you, when the brain is at its most critical and active phases of development. The younger a person is when exposed to trauma, the higher their risk of developing trauma-related disorders, including learning disorders, developmental disorders, cognitive deficits, attention issues, attachment disorders, and so much more. A young brain needs a healthy chemistry to develop properly. A brain that's developing while flooded with trauma-induced chemicals like cortisol and adrenaline fails to form healthy, strong connections. Children are never too young to remember. Please don't belittle childhood trauma as being a lesser form of trauma. The parents who are raising these children face enough struggles. It's my hope to create greater understanding in the world about the effects of trauma on a child's brain. Please share this wide and far so we can all work together to help these children. And please never again say, at least they were too young to remember. So at the beginning of this presentation, I said that while the medical model asks, what's wrong with you? The trauma-informed model asks, what happened to you? And the trauma-responsive model asks, how did you adapt in order to survive? I want to spend a little time here sharing about how trauma impacts the brain. Okay, so if you hold your hand up like this, please do it with me, and you fold your thumb in, and you fold your fingers down. This is a rudimentary model of the brain using your hand. And so if we use this model and we understand it and we help others by teaching it, this can even be taught to small children and is increasingly being taught in like elementary school classrooms by school counselors. But it needs to be taught to parents as well, to everyone. If we can use this simple hand model of the brain to teach people about trauma and its impact and effects, then we can help spread the word. So here you have a hand model of the brain where the wrist coming up to the fleshy part of the palm is like the brain stem. It's sometimes called the reptilian brain because reptiles have this part of the brain as well. So base of skull, spinal cord going down, and the function of this lower, deeper part of the brain is to help regulate those systems that are out of our conscious awareness. So these parts of our brain are the parts that regulate things like breathing. We don't have to think to breathe. We don't have to remember to consciously breathe. Breathing just happens naturally. Heart beating, right? Digestive systems working. And so our ability to go to the bathroom regularly and things like that. It regulates hunger and all those kinds of things. All of this is our lower, deeper reptilian brain. Okay. Then if you open up your hand, your thumb will represent your limbic system. Your limbic system is the midbrain. And here in these limbic regions, you'll find things like the hippocampus, the amygdala. This is where sort of all mammals have this part of the brain. And this is the part of the brain that reacts in a split second to perceived threat in our environments. Now, it's not the part of the brain that makes plans on how to help us overcome threat. Planning does not happen here. This is the split second perception and reaction response to perceived danger in the world. It's that idea of like I'm walking through my land and all of a sudden, before I know it, my heart's pounding and I've jumped sideways, and it's all because I've seen a wavy, skinny, wavy thing on the ground, right? It's that almost innate response that happens in the blink of an eye to protect me from perceived danger. Now, when this part of the brain is active, it stops the limbic system, or this is limbic system. It stops the brainstem, that reptilian brain, from functioning the way it typically functions. So when this part of the brain has been activated, the limbic system has been activated, all those systems that I mentioned earlier change automatically. Breathing gets faster automatically. Heart rate gets faster automatically as the heart is pumping out chemicals for fight or flight to occur, pumping out blood to the extremities, and the cortisol and the adrenaline and other chemicals are being pumped out too by different brain areas. And so all of these things are occurring. So our digestive system goes offline. It stops working properly because everything is happening in order to prepare us to either run away or fight our way free from perceived danger. Okay, and all of that happens automatically and quite quickly, split second response. Okay, so that's what's happening here. Then if you will fold your hand back down, this is representing the sort of youngest developmentally part of the brain. This is the cortex, okay? And not all creatures have this, but humans, of course, do. And then I want you to look at a very specific part of your hand where your two middle fingers touch the fleshy part of your palm, and they're simultaneously, you can feel the pads on the back of those two fingers. They're touching the limbic system. They're touching your thumb. That is your prefrontal cortex. The prefrontal cortex is something that only humans have, and it enables all kinds of wonderful things to occur. Like that planning. This is where all those executive functioning things occur. Planning, connectivity with others, creativity comes out of this place. Calm, a sense of calm and settledness in the body, in the environment, takes place when the prefrontal cortex is right here, is online. Now, when our lids are flipped, right? Go like this. When our lids are flipped, we can say that we act like any other mammal. We no longer have all those wonderful C words, connection, creativity, calm, all those wonderful things that happen when the prefrontal cortex is online. We no longer have those operating. We are operating out of our limbic system. We're operating like any other mammal, like any monkey or ape would behave. We can't think rationally. We can't think logically. We cannot learn, and we cannot connect. So if for nothing else, help parents understand that you do not discipline a child when their lid is flipped. You do not try to teach them anything. Discipline is about teaching, right? You don't try to discipline or teach when the child's lid is flipped because you're wasting your breath. They cannot learn. It is physiologically impossible for a person, child or adult, to learn when their lids are flipped. And so first, you need to put the child in an environment in which they can calm down and their prefrontal cortex comes back online. And then you approach the child with the discipline, either the punishment or the reward. Reward works better. Punishment has the potential to reflip the lid, and then they can't learn again. But from whatever happens, you need to, as a caregiver, you need to be providing discipline from a place of prefrontal cortex connection. And you need to only provide that when the child is in a place of prefrontal cortex connection. Now, the deal with trauma, whether it's developmental, so it's complex PTSD, or whether it's a single incident trauma experience in adulthood and it's sort of a simple PTSD scenario, is that the person perceives danger in the world more of the time. And they are walking around acting like any other mammal. And this is pathologized in the medical model. But from a trauma-informed approach perspective, we know that this is not about there's something wrong with the person. This is about the way that trauma has impacted their brains. And on a split-second, non-rational level, they are perceiving danger in all kinds of places where it doesn't exist. Their bodies perceive danger, sometimes in an ongoing way. Chemicals are constantly being flooded into their systems, which makes their systems then adapt accordingly. And all those basic functions that the brain stem, those lower, deeper, oldest regions of the brain, all those functions are now not working properly. They won't be sleeping well. They won't have proper digestion, so they won't have regular bathroom habits. All those lower levels of hierarchy, Maslow's hierarchy of needs, are not going to be being met. And this is very, very important to understand, because if you try to treat trauma from a cognitive perspective, from a CBT type perspective where you're focusing on thoughts and beliefs, if you try to start there, it will not work, because the person with PTSD or complex PTSD, their lid is flipped a lot of the time and they cannot learn. They cannot rationally examine their thoughts to see whether their thoughts are rational or not. They're almost incapable of doing what Scripture encourages to do, which is take every thought captive to Christ. They cannot do that process because the thoughts are not what's happening. It is the limbic system driving the boat. The limbic system is keeping all of the prefrontal cortex goodness from operating, and the limbic system is also preventing the deepest brain, that brain stem, spinal cord, from keeping all of the systems operating properly. Okay, yeah, so this is your brain on fear. Most of the regions shown here are in the limbic system. Remember that midbrain area. The hippocampus, the sensory cortex, and the amygdala are all areas of the brain that establish situational and emotional context and officially deem the situation as fearful and dangerous. And then the hypothalamus is where fight or flight response is activated. Messages are sent out to the kidneys and adrenal glands, which releases stress hormones like we were talking about earlier. The thalamus is essentially acting like a giant switchboard, and it directs information to other parts of the brain. And then finally, the frontal and temporal lobes are higher cortical areas where experiences of dread occur. They release chemicals like dopamine that cause a panic, irrational behavior. And all these processes occur in a split second without conscious and rational thought. And a brain that's experienced traumatic overwhelm in the past is more likely to believe that danger is present in the current, even when it's not. And so what I want you to know about treating trauma is that there's a very intentional, stage-wise process that must be adhered to. Stage 1 is establishing safety and stabilization. In this stage, you establish rapport, you engage in assessment, diagnosis, and treatment planning. And then there are 2 different kinds of safety that must be achieved before you progress to stage 2. The first is interpersonal safety. This is safe in the world, safe in relationships. The person must be able to trust that their basic needs, remember that Maslow's hierarchy pyramid, those lower levels, are going to be consistently met. Their relationships need to be supportive and not destructive. They got to be able to sleep well. And then there is intrapersonal safety, safe in my own mind and in my own body. The person must be able to return themselves to a state of calm when triggered. What many untrained or poorly trained mental health professionals fail to understand is the importance of remaining in stage 1 until interpersonal and intrapersonal safety and stabilization have been achieved. If we rush to stage 2, we put the client at risk. Best case scenario, treatment doesn't work. But worst case scenario, we risk re-traumatization. The client actually gets worse, not better, as a result of our stuff. We can cause severe damage. Also, if the person has coped with trauma through an addiction, we would put them at risk for relapse there. Many counselors don't realize that some people need to remain in stage 1 for years if necessary until they have truly achieved intrapersonal and interpersonal safety and stabilization. And then stage 2 is remembrance and mourning. The tasks of this stage are reconstructing the trauma narrative and grieving losses. This is a stage that most people think of when they envision trauma treatment, because this is the place where the traumatic event or events are revisited, desensitized, and reprocessed. And when they've been fully desensitized so that they no longer cause distress, and fully reprocessed so that the after effects of the trauma, all those symptoms of intrusion, avoidance, negative cognition and mood, and arousal and reactivity are all resolved, then and only then is the client ready to progress to stage 3, reconnecting with life. This is the stage for enabling post-traumatic growth. I just can't stress enough the importance of being thoroughly trained in treating trauma before you undertake it. Please, please don't dive into the trauma narrative asking for details of the trauma when working with your clients. Please ensure that you fully comprehend what trauma treatment should entail before you attempt it. So there are a lot of great options for treating trauma, and the recent expert recommendation is that clinicians offer a variety of modalities so that they can help each unique client. So there's EMDR, eye movement desensitization and reprocessing, exposure therapy, especially graduated or systematic exposure, TFCBT, which is trauma-focused CBT, somatic experiencing, sensory motor psychotherapy, ABC, which is attachment and biobehavioral catch-up, TheraPlay for attachment healing, DBT, dialectical behavior therapy, CPT, cognitive processing therapy, PBSP, pesoboidin system psychomotor, TRE, tension and trauma relief releasing exercises, IFS, internal family systems, expressive approaches like visual art making, theater arts, dance and movement, expressive writing, etc., fascia massage, and EFT, emotional freedom technique, which is like the meridian tapping. I can't teach you any of these in only a few minutes' time, but I can encourage you to find a place to begin, dive in, and learn. And I recommend taking a course specifically focused on trauma if you can. Yeah, so I know that this was a lot of information. We've truly only skimmed the very surface of what it means to be trauma-informed counselors who are competent to treat trauma. I'm passionate about trauma treatment, if you couldn't tell, especially considering the generational impact that healing can bring. And thank you for your attention to this presentation.